Thank you, sir. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. So the session is already on, and I'm Dr. Yaqoob, endocrinologist. I will take you further down the session. And right now we have got a brief talk, and that will be followed by a panel discussion on this wisely chosen topic of the biosimilars in our country. The talk, we will try to keep most of the time for the panel discussion, because the panelists and the speaker we have got, they are really elite endocrinologists. So I will request the audience to please stick around till the end and interact, so that you can learn a lot from the endocrine gurus we have got. So straight, I request the speaker for the session, Professor Dr. Abdul Jabbar Sahab, to please come over the stage and take over the podium. Sir.
Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. Thank you for Dr. Kashif to set the stage very well. You might feel it's a duplication, but I will try to make it more simple than he did. These are my disclosures. The issue about pharma biosimilar has got different aspects. So Dr. Kashif has addressed a lot about what is the role of pharmaceuticals and the authorities which approve it. But in his last slide, he mentioned at the end of the day, it comes to the clinician, the patient, and the payer. And many of you know I've been away for many years, 15 years. I know one thing, very simplified. Thyroxine is not a biological. What is it? Oh, he gave it a lecture. What is it? It's generic, right? So many of my patients who were under my treatment here, some of them were using thyroxine 200 micrograms per day. And then they came to me in Dubai to see. And I offered them, what would you like if you're coming to see me? And they say, what you say. For some of them, if they can afford to come to Dubai to see me, I think they can afford thyroxine, right? And would you believe many of these patients are now taking thyroxine 100 micrograms. So this is the simplified approach of the changes in the generic. And we all know in the last 10 years, especially related to diabetes, so many of the oral agents have come, and what was the innovation is different. But what is available mostly in Pakistan is generic. तो मैं हमेशा कहता था कि प्राइस भी तो देखनी पड़ती है ना. थायरोक्सिन अगर नुकसान नहीं दे रही और मुझे 200 लेनी पड़ रही है तो कोई बात नहीं, इसके बावजूद सस्ती है. 200 लेने के बावजूद सस्ती है. तो why should I go and buy an international brand which will give me the same efficacy? So he has very well summarized the aspect in terms of the efficacy, safety, but another thing is for how long we'll keep. So he touched upon some of the newer biologicals or biosimilars coming from China. China is quite a rich country, right? But they don't buy from there. And the biggest issue came when the COVID pandemic came, right? Where did the first vaccine to Pakistan come from? Nobody asked what biological it is, and he very well summarized, it was a biological. Then came from US, then came from UK, Pfizer and Wellcome and everything, but we have already used that one. And some of may still say कि सारे side effects जो आज हो रहे हैं उसी की वजह से हो रहे हैं, but I won't agree to that. Anyhow, so going back, biological medicines, as he has summarized, are large molecules. They are used in various aspects: detection, treatment, prevention, and the biggest factor nowadays is coming, especially from the perspective of diabetes, is there are so many biologicals available which may be game-changing. But unfortunately, majority of the patients who deserve it are unable to afford it. So if other companies across the globe are coming, and especially from Pakistan, we have to address the situation in various questions. So I'll just set the stage, and our colleagues, the experts in the field of diabetes, will comment on how should we look into that. So these are the summaries, as he has already mentioned. Low molecular weight, non-structured, as I always ask to make it simplify, what is the formula for salt? Sodium chloride, correct? Whoever is making it, whoever is selling it, it's sodium chloride. But not everybody can make it, making it more. What is the formula for water? Can we make it? No. Making is the job of pharmaceutical, right? But is it simple? Yes. Water will have the same thing, same efficacy, same safety, unless you put some contamination, which he has addressed. If the contamination is taking place, it can generate immunogenicity, food poisoning, etc. So generic molecules are very simplified. They can be managed very well, but the biologicals, and among the diabetes biologicals, the number one came into one was insulin. Everybody knows the formula of insulin, right? Can anybody tell me? There are two chains, but the formula nobody knows, right? And if I put the 10 names of the insulins which you are using, even I don't know the formulas, right? So that is what is the simplified approach of, they are large, complex, biological molecules. The first DNA-generated insulin from Lilly was made by E. coli. Nearly the same time, the next one from Novo came from yeast. Totally different. But when we use for our patients, there is no change in the dose. The same dose of humulin, the same Novolin. And it's equally effective. Are they biosimilar? No, because they didn't get approved because of the biosimilarity. They got approved because of their innovation and their clinical data and everything about that. So moving forward further, the generics are copies, exact copies of small molecules, but the biosimilars are similar versions. They are not identical, but they may have the same clinical effects, same side effects, and it has to be proven by the company which is making biosimilar that it is not very much clinically different, it is not very much safety concerns, and it will not give you a different immunogenicity signal. Why we are talking here in the panel today, but who are the authorities which will be looking into that and approving? That's the most important question. And as he mentioned, I will not say that, but obviously, if you don't trust one person, you have to go to the other person to get the certificate of halal. Correct? Halal है या नहीं है? इस पे लिखा है halal है, मैं नहीं मानता क्योंकि जिसने लिखवाया है वो गलत है. Right? So that's why I'm making it life simple for everybody to understand before the panel comes into the discussion. So biological offers new treatment options for real of life-threatening diseases, but at the same time, it is changing because biologicals are the key treatment options for many of the most common number one disease in the world today. So one, diabetes everybody knows, and in the next 5 years, we'll not be talking about diabetes, we'll be talking about obesity. Again, biologicals, right? So very much dependent on that. And the impending patient expiry set the stage for the new biosimilar drug development. So the expiries are patent so that other pharmaceuticals are able to design, develop and claim biosimilarity. And as I always say, I was part of the Lilly when we launched Abesaglar. And when my company had told me we are bringing it and we want to replace Glargine, my question was, it is biosimilar approved, but what cost will you give? If you say we will give 10% discount, now I'm talking about the role of clinicians, right? So clinicians in a role to play, how much will it cost so that majority of my patients can benefit, but there is no product in which 100% of the patients can afford it. So the 2015 global market penetration expected to be 2 to 2.5 billions. So understanding the concept of biosimilarity is essential for the clinicians and patients. They were first introduced in Europe, he has mentioned it, but some of you can see growth hormone, erythropoietin, colonial stimulation factor, monoclonal antibodies for TNF, at least 1, 2, 3, and 4 are essential. And people die or are restricted a lot because they cannot afford the treatment. So if somebody can say it is biosimilar, which again I mean the same thing, not significantly different clinically, there are no major safety or immunogenic concern, and it's not made by the innovator company, and it has been approved by the approved authorities in terms of the biosimilarity criteria, which my friend has mentioned a lot. So this is the list of many things which has come, and touching on that, what were the problems? When the human growth hormone came, whatever was the company making all the efforts into that, they did all the effort. They designed, they purified. And biological is not you make in the lab. You make into the biological agents, bacteria or yeast or something like that. And because of the antibody formation and residual host cell production, it was not approved. They put all the efforts in that. The second one was again thioether variant structure in the human, lack of efficacy. So they were designing it by whatever mechanisms are there to be biological similar. So biological similar we don't understand, but the biologists understand it, they know. So one who is making the insulin, he knows the peptide length, the peptide molecule, amino acid structure, and based on that he is designing and he's making it, and still it could not be approved. The same thing happens the erythropoietin alpha. Because of the immune effect, neutralizing antibody. So in the lab, it is same. But when it goes into the human body, the neutralizing antibody is there, so it cannot work. So even though it may be half the price, it's not working. The failure of erythrocyte formation because of the antibody. The purpose is not served. Not fit for regulatory approval in the Europe. Now, human insulin developed by Marvel, they took a lot of things because of the lack of immunogenic data. So they did the clinical studies and everything, but they couldn't show that immunogenicity is the same as the original human insulin. It wasn't approved again. And interferon alpha. So besides the production of the molecule, then the structural changes which depend on the folding and synchronization and the other aspects, as he mentioned, in terms of the final stages of purification, there are certain things take place which the molecule may be the same. They say, oh, it is the same as the semaglutide. But when it goes to the human body, because of the final stages, if it is not performing the same, I give the example way back when I went back out of Pakistan, maybe 25 years or back. There was one company which brought to me insulin, biosimilar. And they had very many meetings with me, and they were planning to launch it. I say in the setting like this where we are, which is maybe 25 years back, I cannot start prescribing it or suggesting to my colleagues unless you give me a lot of 100 patients who are already on insulin, I switch them by taking their consent. And if it proves in terms of the clinical efficacy and no side effects, I will give you a report. But we'll have to sign. If the result is otherwise, still I will publish the report. They never came back to me. So that tells you the story. So there are process-related immunities, formulation, expients as well. So they are complex products because the host cell may be different. The innovator company used E. coli. You are not using E. coli. You are using something else. You are using it. The extraction mechanism may be different. Purification may be different. Post-fermentation may be different. And formulation may be different. So there are so many aspects one has to consider. And as he mentioned, because of this, across the globe, and that's why people are saying FDA was the last to approve biosimilars. It came first from the EMA. because they are more rigorous about the approval process and they look into everything. So proof of quality and bioequivalence is enough. No substantial clinical data is required and generics are easy. But because of the different manufacturing processes, after the quality of a biological medicine is demonstrated, some non-clinical and clinical studies are still necessary to prove, and the immunogenic response has to be achieved as well. So coming to the points of discussion maybe today, the number one is innovation, which we don't do it. The pharmaceuticals which is making the biosimilar, they bring to us after doing everything. This is innovation, but it is biosimilar. When they bring to us, they don't say it is Clargine. It is biosimilar of Clargine, but still they cannot say because it is biosimilar, it is half as effective. And Kashif very well showed, if it is 90% effective, I may take it, right? And that's what I am saying. So this is important calculation which has to be done in the real world, because nothing in the biological could be 100% the same. But two important things are immunogenically and safety. There is no compromise. But the efficacy wise, as I just gave you the example for thyroxine, which many of my endocrine patients use, I don't mind if they have to take 200 and pay double the cost, but still it's the price is 10 or 20%. So, but then it comes to access, and these will be the questions will be discussed. Access is number one, my hospital approved it, right? So it's in my formulary now. And my hospital approved it not because they liked it, because XY authorities have approved it. Now the patient comes to me, and this is the real world situation again. All of you prescribe statins, right? Now, how many atorvastatin brands are available? Right? One more, you forgot one. So, 551. 51. Ah, that's the original one, right? So, that is available and it is cheaper. But who decides what I write? I decide, correct? So if Lipitor company I will like Lipitor. I don't like them, I will like the other one, right? So this is the clinician's role. I am practicing in an environment where this is not a big factor because it is always paid by the insurance. So in my hospital, they generated the generic formulation. The doctors can only write atorvastatin in my hospital. All the doctors, not at all. It's my patients, it's my prescription, it's my decision. Who are you to deal with? What are they saying? It's cheaper. Oh, you are not paying. I'm not paying. Who is paying? In our environment, insurance is paying. Insurance is paying to the patient. Why? Because he paid the premium. Right? So now the patient say to me, Doctor Saab, Lipitor लिख के दीजिएगा वरना वो कुछ और दे देंगे. So that comes to the real life situation in which, so access is there, but then the options are with the doctor, with the patient, and with the payer. But in some of the big organizations in the health system, this is crucial. Like in the NHS, they write generics. And then the pharmacist can decide what to give. And how the pharmacist will decide? Cost. So cost savings are important. Patients seek information primarily from their healthcare providers, doctors, nurses, physician assistants, and pharmacists. They are trusted. And if the product is good, and in the setting like ours, it is working, it is clinically effective, there are no safety concerns, and is available. So as I say, if these things come in the market and properly approved, the patients will ask you and me, Doctor Saab kya kehte hain? Le loo ya nahi loo? So we should be aware about, and we should be looking into the approved authorities and the method they used for the approval. So I will stop here, and then maybe panel will discuss many of the questions related to some of the hints I have already given you.
Thank you, Professor Abdul Jabbar Saab. So, two wonderful back-to-back lectures on the biosimilars. And now it's the time to actually go and ask our endocrine giants some of the practical issues in prescribing these medications. So, please, ladies and gentlemen, welcome on stage the panelists for this session. And these are Professor H. Aamir Saab and Dr. Abbas Raza Saab and Mr. Zeeshan. Please, sir, join us on stage. Thank you, sir. So now I will ask some of the very pertinent questions from the panelists, and then of course you can interact through the barcode. So, sir, to begin with, I will ask you that in a country like Pakistan, whereas in accessibility and affordability is a bigger issue, so the simple question, why actually we do need a biosimilar, Professor H. Aamir Saab, from a clinician perspective?
Thank you, Yaqoob, and again I must congratulate the organizers and scientific chairs for organizing such a wonderful talk. Before lunch, people are standing behind. You can have a look back, and people are all standing. So it's a wonderful testament to what the program is. Now, I think your question is very relevant. I think the final slide which Dr. Jabbar has shown, and one thing which was just striking to me at the time sitting in front was the access. And I think we have seen this in insulins. We have seen this in many drugs, that access is something which we always struggle. Who doesn't know that the weight loss is good? Who doesn't know the statin isn't good? We all know that. But whether my patient can afford or not, in countries like ours, or even further lower income countries, the access to the treatment which is established by the guidelines, the handicap is that how that access is going to be available. So I think these biosimilar, we're going to carry on talking about biosimilar and bioequivalent, and I sometimes lose track of what am I talking about. But I think we're going to carry on talking about this. But I think one thing which will define is that how much we were able to make it available to our population in general. And that again will define that what kind of product we are looking at. So for me, in lower income countries, the competition goes up for obvious reasons. And obviously in competition, it's the benefit of the consumer. And consumer here is our patient. So I think in all fairness, the access is one big key. The competition is something which will creep in. And I think the benefit will goes to our lower income population, and the accessibility will be generally increased overall.
Thank you, sir. So another question, it's a little challenging. How we do actually justify the use of these biosimilars over the reference biologics? So I will ask Dr. Abbas Raza. It's a very challenging question, sir. For example, the accessibility and the affordability issues that is not there. So how you justify using this biosimilar instead of the reference biologic that is available?
Thank you very much for an interesting question, and Aamir will answer for me. So it's just, no, yeah, I'm just kidding. So I have two quick comments, and I'll come to the question that you're asking. Number one, I'm so happy that at the prime time show time, we are talking about biosimilars, bioequivalency, and whatnot, because about 3 years ago, I can take the pride in when during one of the PES meeting and asked my fellows, I probably didn't know either. But again, I asked my fellows, endocrine fellows, about what is a generic, branded generic, what is a biosimilar. And most of us actually didn't know the exact concept of it. So I'm so happy that we're talking about it. So that's one component of it. The second component is that all these issues rise when there is, and I'm sorry if I'm saying it from this platform, arise when you're talking about the generics, when the original brand is still patented. Once the patent goes off, there is no usually talk about it. So if you look at liraglutide, there was a big debate on how the liraglutide is the best in the world, and again how the generics are useless. But since it came off patent few years ago, there is no, FDA has approved it, everyone is using in US, and I think these discussions happen before the patent comes off. I think the discussion on semaglutide that we're having is going to stop in about 2 years' time, or I think in about 2 months' time, when SEMA is coming out of patent, and the talk will now shift to tirzepatide, how the changes are. So there is a natural inbuilt bias in when we discuss these topics in general public of how we are dealing with generic versus. So I think these 2 points have to be clarified before we go any further. Your question was very important. What's the relevance of branding? I practice in a certain area of Lahore, in which, and I usually never do, but let me give you the name of the medication. So if I'm writing a glimepiride, the patient would say, you know what, I will write, and we're in the Getz Symposium, and Getz makes Getril, so let me name Getril. So I'll write down Getril, 4 milligram or 2 milligram. The patient will, you know what, मुझे ज़रा branded वाली लिखते हैं. So I'll say, okay, I'll write Emeril. And I would generally ask those people, आप Emeril कहाँ से लेंगे? So he will, मैं दुबई से मंगवाता हूँ. So the price difference of Getril versus Emeril and Emeril versus getting it from Dubai is about 400, 500 times. People still prefer getting it because it's the same brand. Emeril over there is the same company and everything. So the unfortunately, the confidence about a drug is something that you develop based on your assigning authority. So if a generics comes in US, they have full faith in it. They never have the question that we are asking today, that what we have. The only problem why we're discussing even today is, what is a biosimilar? What is a synthetic biosimilar? What is the biological side? What is a synthetic product? How the synthetic product, the molecule size matters. How the tirzepatide would make a difference in years to come because it's a synthetic product. It's a smaller. Would we be having the same discussion when we talk about tirzepatide? So discussion only arises, and I'll quote one controversial thing before I finish and leave a mic to the expert. India is launching, I think, 13 brands of semaglutide in 2 months, because semaglutide is coming off patent. We've launched it because we can do in Pakistan the rules are different. So they are launching one, and I got a call day before yesterday by 2 of the presidents of the organizations of India, and I asked them, which one would you prefer? The answer was based on the price. So they also have some kind of a trust in whatever things are coming into the market. It's already passed the bar. Because as clinician, I know how, no matter how smart I would want to look in knowing the biosimilars and the bioequivalence and the safety data. Honestly, at the end of the day, I rely on experts who tell me that data. And honestly, if you go to 5 different symposiums, the 5 different symposiums will be telling you different. To summarize, I think that in this current market, we need to decide what the efficacy of the safety of the patient in my test book comes in. I don't think if there is a cheap medication which is harmful for the patient, I would want to write that. So that's a strike off for most of us who's a clinician, because we would never want, even if it's cheap, even if it's something very important. Then cause the effective. And before I finish, I'll give you a quick example. Tirzepatide and semaglutide, when it was not available in generic, people would ask me, which one would you prefer? And I would always say I would prefer semaglutide. Why? Because semaglutide was launched in Pakistan at 25,000 or 20,000. Tirzepatide is imported from Dubai for 1,50,000-60,000 rupees per month cost. The efficacy difference is 15%. So I cannot justify writing someone a tirzepatide which is costing 10 times more just based on the efficacy and the cost effectiveness of it. But if tirzepatide comes at the same price, then I will have to think that it is more efficacious, it's more beneficial, and probably I'll write tirzepatide more. So our practices have to define, number one, it should not be harmful for the patient. Number two, someone has to tell us that the studies have been done enough, and I will pass the baton to our expert here. If the studies were done on our generics which are available, and the safety is there, because I cannot analyze that data. I maybe should, but it's very difficult. And then the safety of the patient comes in. So I answered your question in a long way, but I hope I got the gist of it.
Thank you, sir. You're pretty very well explained. Now I will ask Mr. Zeeshan two quick questions. Can you tell us about the DREP approval pathways? Because the audience is also asking this question of these biosimilars in our country. So if you can just explain, shortly this question.
Assalamu alaikum. So before I answer the question, just to give you a brief background what I do, I have an experience of registering product in around 40 countries, so I know the regulation of about 40 countries. I've worked very closely with WHO pre-qualification program. I also got a training from IBI, which is a global hub in Korea, South Korea, for biological manufacturing. And unfortunately, if we see a Pakistan scenario, WHO classify a regulatory authority in 4 maturity level. Maturity 1, 2, 3, and 4. And they don't even mention 1 or 2 because they think that 1 or 2 is a substandard and not at a par level. And Pakistan does not even right now in maturity level 2. They are working to go to maturity level 3, but not in maturity level 2. India, as compared to us, they have qualified for maturity level 3 for biologicals and vaccines. And this is an unfortunate scenario. So the regulatory pathway of registering a product in Pakistan is, though they have a baseline guideline, but again, if you see the practicality, if you go to the DRAP website, what they do transparently, they publish the minutes where they assess the data and register the product. So for biosimilar product, they had this regulation that the product should have a COPP, means from the products being imported, it should be registered there. It should have non-clinical data. It should have phase 1 compatibility data, phase 3 comparability data. But if you go through, unfortunately, semaglutide registration procedure, the way they have followed it, there are 3 registered semaglutide in Pakistan. And all these 3 semaglutide had submitted variable data, and unfortunately, all 3 got registration. So if I talk about Getz Pharma, we have submitted non-clinical data. We have submitted phase 1 clinical data. We have submitted phase 3 biosimilarity clinical data, head-to-head comparability study. But there are companies who have only submitted phase 1 data, or a company which has submitted no data at all. But all of them got the registration. So again, this is a dilemma which we are facing. So people who are related to healthcare professional, what they can do, they can ask for the relevant data. Obviously, they cannot interpret the data, but at least they can ask for the data. If the data is there, at least we have this sort of, satisfaction that the studies were conducted. And we are talking about biosimilars. I have studied even small generic like pharmaceuticals. A product called sofosbuvir used for hepatitis C. It has 5 polymorphic forms. All 5 polymorphic forms are sofosbuvir, but only 1 polymorphic form is stable. And there is no way here in Pakistan whether we can assess that which polymorphic form is used for the like formulation of sofosbuvir. Then there's a product like mirogabalin. We were formulating it. We couldn't able to bring it earlier. And why we were struggling not to because of the efficacy. We have reached to the efficacy of mirogabalin, but it is so sensitive from light and heat that immediately degrades. And when I sample few of the available product from the market, it has an impurity level of 10% where it should be of like less than 0.5%. So this is the problem we are facing here in Pakistan. What we are doing as a leading company, we are not only what we should do, like we should select the right formulation, import from the right supplier, do all the studies, but we are also pushing DRAP to like increase their level of assessment. We are suggesting them, we are counseling them, we have working group, we are influencing. There's a new CEO in the DRAP to whom we are talking that we should upgrade the level of the barrier before we bring in the pharmaceutical product and also biosimilar product. And lastly, I would also like to emphasize that in the guidelines has been written, like European guideline has been written, US FDA guideline has been written. They have been written for the vertically integrated process from the plasmid, recombinant technique where the genetic modification is done and then culture and then harvesting and purification and then finished word. In Pakistan, the scenario is completely different. We are not doing initial 2 to 3 steps. We are importing a bulk or a concentrate. We are doing the dilution and then doing the formulation. So we need to have a tailor-made adopted guideline using the reference of USFD and Europe, but we need to have our own guideline to assess and safeguard the interest of our local population.
Thank you, Mr. Zeeshan. Now, very briefly, another question, the second question from you. These biologics, these biosimilars rather, for example, if I say the semaglutide, nowadays, it's being prescribed right and left everywhere. So how the problem of the counterfeit medicine, how you can tackle that, and how the healthcare, whether the policymaker can help you in this regard. So what is your take on this?
Yeah, so counterfeit is, again, this is not, we should not see this counterfeiting as in isolation. To give some credit to our local health authorities, especially in Punjab, now we have around 4 to 5 WHO pre-qualified drug testing laboratories who has this capability to at least test the potency, if not the safety, because they are not assessing the impurities. So counterfeit is a general problem. Again, if you have, if like in US and even in Europe, they have established a track and trace system where they are like combating this menace, because there is a problem over there as well. So there's the track and trace, and then enhancing your laboratory system where you can do the surveillance testing. And again, at the end of the day, the overall barriers which is being created to you resist these sort of imports, that can prevent, and then in collaboration with the law enforcement agencies as well.
Okay, thank you. Sir, Abbas Raza. Sir, we do write these medications, and when the patient comes after a couple of months, so the original medicine, let's suppose semaglutide, whatever brand we have written, that is quite at many occasions that is changed. The patient is not taking that one. So have this, the ethical concerns staying around this interchangeability or the automatic this substitution of the medicine. So how do you see this problem? This should lie with the prescribing physician, or directly with the pharmacist, or with somebody else?
So an excellent question, which I don't know if there's a short answer for that, but I'll try to answer it. So that brings down to the point which Dr. Jabbar has very nicely pointed out. As the clinician working in an institution, and I'll give you Pakistan, in Shaukat Hanum, I cannot write a brand. It's the responsibility of the institution to get me the best atorvastatin that is available. It's the responsibility. They do their due diligence. I can never write a piece of paper that you need to take this brand and again, because you need to trust the same is true in the US as well. In Pakistan, we talk about different brands. And again, very rightly pointed out, if you have a brand which is known to have impurities, which is known to have problems, as an ethically practicing physician, whoever that is, wherever that is, if the person decides to start taking that, you have to make an informed consent with the patient that, the reason I would not have used this is based on this factor. This is a private pay. Even then, if the patient decides to take that medication, but as a doctor, it's your responsibility to guide them in the right way. I think that's where we talk about the branded generics versus generics which are available. Because you and I both know that in a hospital, you might find a drug which was worth 10 rupees in market, you can get it for 1 rupees and again, the quality and the efficacy goes down significantly. So as a physician, it's your responsibility, unfortunately, this probably should or should not be your responsibility, but in Pakistan, it's your responsibility not only to know a medication, but also know the sources of a good medication. And probably semaglutide is just the beginning of it. Tirzepatide, all these new molecules that we are talking about, and unfortunately, and again, with due respect to everyone in the industry, the problem is If Aamir comes to me and tells me about his product, and Dr. Jabbar bhai comes and tells me about his product, Dr. Aamir will tell 10 different wrong things about Jabbar bhai's product, and Jabbar bhai will tell me 10 different bad things about Aamir's product. And then, as a receiving, who would I rely on? I cannot go and test those laboratory. He's quoting one laboratory and he's quoting laboratory. The problem is this mudslinging becomes difficult, and then as a doctor, your job becomes even more difficult. I'm a big advocate of knowing the truth, but unfortunately, that truth is sometimes hidden inside it. So, which medication, how to use it is important, and changing the brand would probably is a responsibility of the doctor's physician to decide.
I may add, and I think Abbas, you would agree that that's where the real world studies do creep in. And I think this is how we may be able to decide what is right for our patient. But again, it takes time, it comes at a cost, and that becomes sometimes difficult. So I think real world, or for that matter, even operational data, a lot of us have got HMIS system available to us. And if you have operational data, I think that could be a good source to gain your confidence. And I think many of the institutes, private and public even institutes, have got HIMS data. So just feed it in and then get that information, real world evidence based on what you have fed in. And if you can keep the follow-up of the patient, that's a good evidence for us and good satisfaction.
Thank you, sir. So, Professor Jabbar Saab, you're sir practicing in Dubai nowadays, and sir, how do you see the future outlook, the future of these biosimilars in Pakistan, the lower income countries? Do you believe in the widespread adoption of these molecules in the near future?
Biosimilars are going to be the future. What I was thinking when giving the talk and having learned the discussion, we talked today about the availability of insulin for type 1. These kids will die if they don't get insulin. And at the moment, fortunately or unfortunately, there are donors from the international platform who are donating us. And if they don't donate enough, some of our type 1 will not get insulin. Who will pay for it?
Exactly.
Number 2, a very good effort I learned on our group from Punjab, from KPK, the government initiative. But I'm not sitting there or here, I am part of the same country and people. Every country, every province, every health system has a limitation. So if I can afford 10,000 type 1, and if my city or my province has 20,000, who will pay for that? So biosimilar is a very important thing. I was going to ask the crowd here, I'm not talking about semaglutide. I think personally so far, it's not a life-saving medication as yet.
Insulin is.
But for insulin, I don't know in the big crowd here and my experts here, if anybody is using the biosimilar insulins available in Pakistan. Sitting back there, in the last 3 years, I got, as I say, some of patients consult me, talk to me or send me on WhatsApp, etc. And 2 of my relatives were given insulin, biosimilar, and their glycemic control was so bad. I say, which insulin you are using? And I got the name, which I didn't know. I stopped them. I changed them to the one we are using, the international brands. It made a big difference. So what do I conclude from there? Although it was approved, it was labeled as biosimilar, but it was not working. I got at least 3 patients who are using, now I will say insulin, which I know are not the brands. They are doing very well. When the generics came, that's why I was giving the example of Lipitor, all of these doctors here are using SGLT2 inhibitors, DPP4 inhibitors, not brands. 90% in Pakistan are using generics. Do all these work? They are the judge, I am the judge, as Aamir said. The real world evidence is there. In these generics, we are not too much worried about the safety concern. It will not kill a patient, it will not develop immunogenicity. But we learn by onset. And the second thing comes as well, in terms of the brand as well, an insulin coming from Lilly or Novo, everybody trusts. So we have to identify the setups in our country as well, that this XY has brought these innovator biosimilars, and we found our experience very good for them. So you push for them, get their authorities to approve it. If not in Pakistan, somewhere outside, the data should be. But we cannot sit and do nothing. We have to move forward. Like if the patency is a patent is an issue, is a different one. But if, as I say, insulin is not a patent now, but we are still not self-sufficient for that. Yes. And how long will it take for us to keep waiting that somebody else sets the rule and does it?
Thank you, sir. So because of the time factor, I will ask Professor Aamir Sahab to conclude the session.
Thank you very much. I'll take the final word. As you said, sitting and not doing is not an option at all. So we take it further. I think this is a one way forward. In a way, discussing it, talking about it, shying away from these topics is not an answer. And I think this is more insight now. It's a wonderful session. Thank you very much for my colleagues, Dr. Jabbar coming all the way from Dubai, Abbas, Kashif. Thank you very much. And I think we'll keep on learning, and I think we'll build on what we have learned today.
Thank you, sir.
very much.
So indeed, a wonderful session. We are so grateful on behalf of the Pakistan Endocrine Society to the audience and the distinguished panelists. And now I will ask the Dr. Uniba Sayyed to please take over the podium. Thank you.